Hi everyone, and thank you for tuning in. I'm Dr. Zoe Williams, and you're listening to the Visionable podcast, the show that shares the views and perspectives of leading minds in healthcare. In each episode, I'll be interviewing leaders and experts from across the health and care landscape, discussing their thoughts on the most pressing topics in the sector right now and future innovations. Today we're talking about health inequalities and the barriers to accessing good healthcare with Lord Victor Adebowale. Victor is chair of the NHS Confederation and Visionable's co-founder and chairman. He's spent decades leading organisations at the forefront of health and social care and is passionate about improving the biggest challenges to both public and private sectors. So Victor, thank you for joining me on the Visionable podcast.
It's great, it's a pleasure to be here.
So, first of all, we're going to talk about health inequalities. So Can you explain what do we mean by health inequalities and who are we talking about? Who do they affect?
Right. So the best way of explaining health inequalities is to talk about some work that a chap called Julian Tudor Hart did, I think in the 80s. He was a GP and he came up with the inverse care law. And the inverse care law for me is the best way of explaining health inequalities, because what it says is the people who need health and social care the most tend to get it the least. By which he means poor people, black people, women who are poor, black. It's basically about poverty and lack of access, which is why we got the NHS in the first place. The problem is that inequality, creating equality, doesn't solve the problem, because you've got this issue of inequity. And the best way of describing inequity is the best statistic I often use is a London one. And basically it works like this. A woman in Barking and Dagenham, which is one of the poorest areas of London, has an active life expectancy, i.e. their activity, their body's functioning, their life expectancy is about 55 before they start to lose functions, right? In Richmond upon Thames, which is a much richer area in London, the average active life expectancy of a woman is over 70. So you can see the massive gap in active life expectancy. Now, that's to do with lifestyle, access to good food, actually the stresses associated with being poor, the environment, a whole load of things. In fact, as you know, that about 80% of the things that make you healthy have got nothing to do with health interventions, clinical health interventions. They're to do with externalities, they're to do with where you live, how you live, who you are. So inequity is as important, in fact it's more important in my view than inequality. And just to further illustrate it, there's a really good cartoon, but where you just visualise this. There are three people, one of them's very tall, the other one is average, and then there's someone who's smaller than average, right? And there's a fence in front of them. Now, to solve the inequality of their sizes, you give them all the same box. So that would be equality. You give them all the same size box to stand on. But what that means is the tall person gets to see even more over the fence, right? The average sized person has to stand on their tippy toes, which is really tiring, and still might just manage to see over the fence. And the smaller person, even though they've got a box of equal size, is still staring at the fence. That's equality, right? So if you would deal with the equity problem, right, what you would do is you wouldn't give the tall person a box at all, because they can see over the fence. They can see the football match, rock and roll, right? The average size person, you give them a slightly bigger box so they can see over the fence without stretching and without getting ill and without, the discomfort. And the smaller person, you give a massive box to with steps so they can step with the steps and get over the fence. And that's inequity, and that's how you solve it. It's about giving people what they need in order to access the health services and to design the health services according to their needs, which actually is how the NHS started. The NHS wasn't started by people who were as qualified or as smart or even as me and you. Well, I think they were smarter in some ways. In a village in North Wales, they weren't getting the health and social care that they needed, so they designed an equitable and equal system, because everybody paid into it, an equitable system that gave people access to healthcare free at the point of need, regardless of need. So if you paid in, you got what you needed according to your needs. So it was equitable, right? And what happened as a result is that the life expectancy and active life expectancy of poorer people actually increased exponentially every decade up until very recently, when it started to slip a bit backwards.
I think I love it when you explain it like that, because I think we talk about health inequalities all the time, but I think many people don't really understand it, and we don't talk about inequity enough.
No, we don't. No.
And that's probably for a lot of people listening the first time they've heard it explained, and it's explained in such a way. And I think I can think of my own personal experience. I now work in a very deprived area of London. I work in Peckham. When I was a GP trainee, I worked in Hampstead, and we served a very affluent community, and they got 15-minute appointments. And they'd normally come with one problem. It would be a medical problem. They could articulate, they could speak English, and they got 15 minutes because we had the time to do niceties. Where did you go on holiday? Where I work now in Peckham, people come with very complex health, social, mental health problems, all wrapped up into one. And they have a 10-minute. So that's health inequality. There's a huge inequality. And actually, even if it was 15 minutes for both, that wouldn't be equitable. It should be 15 minutes now and 10 minutes.
Exactly right.
And even that probably wouldn't be equitable, but it'd be closer to.
Exactly. I mean, I would argue the people in Peckham need, they probably need a health service which is happening to them outside the clinic. So, you know, they need support, probably health coaching, probably, you know, the access to gym membership, walking, good food, educative stuff, so that when they're going to, because there's also evidence that a lot of people that go to the GP actually don't need a GP. What they need is something. They need primary care. They need care, but do they need a GP? And it's in poor areas, they need the primary care, right? So they can make the best use of the GP. And when I was on the board of NHS England, there was evidence that actually wealthier people tended to use the GP more, and there is even more evidence now that access to elective care, so, you know, operations that you need, there is a bias towards wealthier people who can navigate the system, know what to say, and furthermore, the doctors tend to act in their interests. And so you have to change the narrative, literally the relationship between the doctor and the patient, in order to account for the fact that poorer people tend to ask for less, whereas middle class people ask for more, and they expect more, and they keep getting more. So, you know, it's oddly enough a system designed for poor people, the working poor, has ended up benefiting the middle classes, and actually not benefiting. It's very inequitable for poorer people, particularly if they happen to be black, disabled and black, LGBTQ, disabled and black. So we have a real challenge of equity in the current health and care system, and it's not just immoral; it's very expensive.
How do we change it? What are the solutions? Because that is a problem, and everything you've said I vouch for, and I see firsthand every day when I'm working in clinical practice. I also think the people that you've talked about, whether it's social deprivation or those more marginalised groups, they have less expectation of the health service. They, dare I even say it, you know, their expectation for the comfort that they will live in. You know, when I was working in Hampstead, if somebody's got a sore wrist,
they'll be on the
they won't tolerate that. That must be fixed.
Absolutely.
Whereas, you know,
I'm paying for it, so I'm going to go and see the doc.
People sometimes have bigger problems, more personal. If your child is hungry because you don't have enough food to feed them, you know, your aching knee you'll put up with for ages because it's just not at the top of your priority
and there's also
list.
the embarrassment factor of not wanting to go with problems that you think, you know, I'm ashamed I can't feed my kids. I don't know how I'm going to do this. And what we do know is that some of the priorities, some of the major issues in healthcare in this country, you know, cancer, diabetes, you know, have an inverse care law effect. You know, you remember the inverse care law I talked about? So cancer, for instance, black people and poor people are more likely to discover they've got stage 4 cancer in A&E. Even though, you know, you can look at the aggregate and say, well, we might be meeting some cancer targets, but then you disaggregate those numbers and you see poor people actually are more likely to find that they have got cancer in A&E because they're not getting access. They don't feel confident about going to the doctor and talking about their bowels. It's a confidence thing, but also it's a design thing. So you asked me the problem, how do we solve it? The first thing is to say, in the NHS, as I see it, the health and social care system, it's very complicated, but in my view, there are only 3 challenges. equity, we know what equity is now. Access, which is how you design services, who you design them for, who you design them with, and how you staff them, right? That's access, because without that, you haven't got access. And the thing about access is this: for poor people, actually for everybody, but certainly for poor people, you need something called positive value transfer. In other words, the fewer places you need to go to get your health care, the better it is for you and the better it is for the system. Because every time you transferred, every time you moved on, it costs you time, costs the system money. Poor people often get negative value transfer. So they're pushed on because they've got complex issues. They get pushed on and they get lost between the system. By the time they get in the system, it's more complicated, more difficult. So access. And the third challenge is digital. And it has to be in that order, right? So the first is equity, access and digital. Why? Because if digital isn't helping you with the first two, why are you using it? So it has to help you with the first two, otherwise it's pointless. So if you want to solve the equity challenge, you have to do the following things. One, you have to understand the needs of the population that you're trying to solve, you're trying to work with. And that involves actually understanding them. So I go back to the beginnings of the NHS. The NHS started because poor people, actually working poor people, designed something that worked for them. As the NHS and social care system got bigger, assumptions were made by people who don't know them, don't live near them, don't have access to their knowledge, and they got what they were given, right? They were still paying for it. So the first thing we have to do is go back to the principles of the NHS. How do we build health and social care systems that work for you? So let's try talking to you. Let's try understanding your life. Let's try really understanding your needs, because this is your system.
Let's try bringing you to the boardroom.
Let's try bringing you. Well, I would go further. I think it's about actually saying to the boardroom, what is the purpose? Your purpose as a board is not just to be a board of governance, it's to understand that the services you provided actually have an impact on this community. And you can't do that unless you understand the community. So there are rules for community engagement, right? It's not an accident. There are rules. And the first is you have to listen. Now, listening is much harder than you think, as you probably know doing this podcast. If I tell you that I'm listening to you, it's pointless unless you get evidence that you've been heard. That's the first thing, you've got to listen. Second is there has to be a transfer of power during that consultation or engagement process that means that you can do something during that engagement or after it that you couldn't do before. There's no point in me talking to you and saying, we're really listening, and you feel heard, and then you've got no powers. You've got no means to say, hang on a minute, and I've got all the resource. Right? What's the point, right? That's a problem. And simply, as we know that most interventions that will prevent someone needing a doctor in the first place can be carried out by people who aren't particularly, qualified. They just need to understand. So you need power. The third thing is design. Now, co-design is at least at the weakest engagement, you need co-design. Right? That's the least that we should offer. The best should be you design it. Let's help you design the service.
We will give you the resources.
We will work with you. We will not undermine your language. We will value your knowledge because the people you live here. It's your family, it's your community, it's your health. Tell us what it's like. We will design it for you, with you, not with you. You tell us what you need, and we'll put the system together, which is how we got the NHS in the first place, right? And the final thing that's required is the end result of that engagement. The end result of it all has to be a service that you can describe to your mother, brother, lover, sister in a sentence. That's why we got doctors, that's why we got primary, that's why we got A&E. Everybody knows what it does, everybody says. Why? Because they designed it, right? Back in 1900 and freezing to death. So the point is, if you do those things, you end up with a system which is equitable, because it's driven by the people who are actually paying for it, who actually need it the most.
Question. How do we make that happen? Because that's not how it is. The leadership of the NHS and all the structures that support the NHS and the decision makers, the funding, people who we're talking about, those who are affected most by the inverse care law, those who need the health, social care to serve them, are not at that table?
Well, look, I always start from the position that me and you, and particularly me, and certainly you, and most people listening to this, watching it, are far too lucky to be pessimistic, right? So I'm optimistic, and the reason why I'm optimistic is that over the last few years, there's been a realisation at the top of the office, and at the bottom of it actually, that we can't carry on doing what we've always done, because it's madness, basically.
Yeah.
And so we're starting now to understand that what we need is population health. We need to understand populations. In order to do that, we need mechanisms for talking to them at scale. And there is evidence that there are some shifts. So if you look at the work that Rob Webster is doing in West Yorkshire, where he's trying to solve the problem by understanding the system and how it works, understanding how the poorest access and engage with the health system, and starting there rather than up there. So there are signs of life. What we need is to keep encouraging, keep incentivizing, keep talking about those people that are leading, and we need to talk about power, because one of the elephants in the room in all complex systems actually, but certainly the NHS and social care system, is about power. Who has it, how it's distributed, and how they're accountable for it. So there are signs. I think I am optimistic. I think I have a right to be, and I think I should be on behalf of those people that are in worse positions than me. That I'm optimistic that there are signs that the structures that you talk about are changing, are shifting their attention from the hierarchy to population health, from just clinical interventions to integration of health and social care, to outputs to outcomes, to inequality, which is important, but to include inequity as well. So there are signs that is starting to happen. So I'll give you an example. Some of the work that's been done on the elective care list, when they disaggregate it, it's shown that poorer people, black people, people with learning disabilities, are actually waiting far longer than everyone else.
Yeah.
And so what they've done is change the way in which they manage those lists and how doctors operate right at the front line to ensure that those people not only get the intervention, but get the time and support to actually get the elective surgeries that they should be getting ahead of the people with sharper elbows and more knowledge of the system.
Okay.
And you know what? That you start to reduce your waiting times, because obviously if they're waiting a percentage longer, and you can address those as you should be doing according to need, your average waiting time comes down. So there's signs of life, and I'm not one to be pessimistic and doom and gloom. That's not how we got the NHS, and that's not how we're going to save the NHS and social care system. Let's work with what works.
Well, that actually makes me feel optimistic, so thank you for that. Have you got any other examples of initiatives or projects that are actively working within the NHS to reduce?
Yeah, I do actually. I think the work of the Independent Race and Health Observatory is a really good, strong intervention. So we know that black people, and when I mean black, I don't just mean people look like me. I'm a lovely chocolatey shade of brown, actually. but people who are of colour, of different races, religions, get a very different health and care service to the white counterparts, regardless of their class distinction, right? So there's a real problem. So if you look at cancer, for instance, there's a real issue. And actually, during the pandemic, as an example, the oximetry tests that you use was found to be flawed because inaccurate, very inaccurate. So the work of the RHO is bringing to the attention of the whole system that inequity, and changing the way in which we design services so that black people actually get the service they're paying for and they deserve. So we're getting rid of that inequity, and they're doing great work to draw the attention of policymakers and clinicians, producing what I call excuse removers. It's like, there's no excuse for you to do this unless you don't want it. And why don't you want to? Because we're paying for you, and your job is to actually provide a service to all the people all the time, everywhere, not some of the people sometimes, somewhere. So the RHO is a good example of an intervention that's actually changing practice, changing policy on the ground.
And I guess I see it in my clinical practice, in medical education as well, because for so many years it's been terrible. If we take dermatology as an example, all the dermatology
Yeah.
textbooks are talking about skin conditions in white skin. They
Absolutely.
have a very different appearance,
Yeah.
which means if you're a black person with a skin condition,
cancer, yeah.
you may have been misdiagnosed for
Yeah.
many, many years
Yeah.
and received inappropriate treatment,
Absolutely,
etc.
absolutely. And to add to that, one of the pieces of work I've been doing is about AI, which is a really good example. You know, where you've got some of these AI algorithms
Yeah.
that actually are racist. I mean, they
Yeah.
literally are. There's a real problem with them. And so, what some of the what we're doing is changing the parameters. So you can't have an AI program which is looking at skin cancer that doesn't recognise it in brown skin.
Yeah.
I mean, what the hell is that?
Yeah.
That is not applicable. So these things are being worked on. They are being rolled out. I acknowledge that it could be faster,
Yeah.
could be more efficient, more needs to be done. But let's not slag off what
It's
is being
happening.
done.
It's
Let's
happening.
keep pushing.
And I'm seeing
because,
it bit
yeah.
by bit. I want to talk to you about the pandemic.
Yeah.
And if we're talking about inequalities and health inequity, and we know that the pandemic affected all of
It
us,
did,
it turned our lives upside down, but it affected some people more than others. What's your take on how much it affected people unequally?
Oh, I mean, I set up the RHO during the pandemic because I was partly so outraged at what we were seeing. The first 10 people to die in the NHS were black. If you look at the statistics, more black people died than white people. They died in the poorest areas. The people in the poorest areas suffered more than the people in the middle class. And effectively, what the pandemic did is that it put a glowing red line around both inequality and inequity. It could not be ignored. It was so obvious that the people dying were working in places where they were unprotected, where they had to work, where they were affected by both the economic challenge and the health challenge simultaneously with very little support, and particularly black and minority ethnic people. I mean, it was shocking. It was just bad. And so it left us with a major challenge. Like, what are you going to do about it? How are you going to change the way in which we provide services so that that doesn't happen again? And the first thing we had to do is talk to people. And so the work of the Independent Race and Health Observatory was actually design the method. How do you talk to people? How do you talk to black people? Because, for instance, black and minority ethnic communities were being blamed for not taking up the antiviral, the inoculations.
Yeah.
Well, it's not surprising because they'd
Like
already
another
lost
history.
confidence. They'd already lost confidence. And actually, they'd seen what happens to black people in the service. It's like abandon hope, all year went to here.
Yeah.
So we had to change the way in which we engage with those communities and ask them, how do we communicate with you?
Yeah.
Shall we pay some of you to do some of the education in your communities instead of sending people that you don't trust in to do it?
Yeah.
And by the way, we need to stop blaming you.
Yeah.
These aren't hard to reach. You're not hard to reach. We're failing to reach you. You're paying your taxes. You're not getting the service.
Yeah.
So stuff like that was so obvious. I mean, you'd have to be a committed racist to disagree with some of it, to be honest, because it was just so obvious. And the poverty issue, which is overlaid, so was equally obvious. People in poor communities were in jobs where they had to face people, and because they were facing people, they were getting the virus. So there was a big challenge around how protection, PPE. How do you get PPE to those communities, and how do you support them? I still think that's an ongoing argument, debate. My view, it shouldn't be, but it's still debatable. But it's still being debated by some people. But the lesson cannot be ignored. That you cannot ignore what happened during the height of the pandemic, and indeed is still happening in some communities, and that is that the inverse care law was writ large. And that's why population health became such a powerful intervention in the health and care system, because it didn't matter where you were in the health and care system, whether you were the chief exec or the care worker, you knew that what was happening was unfair, and we had to do something about it.
Yeah. So I think we're at a really interesting moment in time, because I think now you're right. There isn't a single soul out there that can really say this issue doesn't exist.
Yeah.
We know that there is systemic racism within the NHS, and there always has been.
Yeah.
We know that people of colour and people from the lower socioeconomic groups have the poorest health, yet they receive the poorest health care.
Yeah.
So what needs to happen? What are the next steps? You know, where do you see it is improving?
Yeah.
But what do we need to happen next?
Well, I think the NHS as a system needs to start rewarding different behaviours. So it needs to start rewarding bottom-up leadership as opposed to top-down. It needs to start rewarding system leadership, i.e. leadership that is beyond the boundaries of your organisation, that looks at your responsibility to the whole system. It needs to start rewarding outcomes. It needs to start rewarding knowledge of community rather than just accepting that they're out there. That's not knowledge. And it needs to start accepting leadership, which is, the job of leaders, and I've mentioned this before, but it's worth repeating, in any health and care system, is to lead everyone, everywhere, all the time. Not some people, somewhere, some of the time. And it's obvious when that happens, when they're only leading partially, because the results are partial. It's not difficult to see that if you've got hospitals and community services where all the leadership are white, male, appointed by tap on the shoulder as opposed to on the basis of knowledge and skill and understanding, you get these unequal services. So it's all connected. Who gets to lead, how they get to lead, and what they're rewarded for results in the health system that we've got. And if you change that, you get a different health system. So again, there are moves. There is an acknowledgement of that within the system. Don't get me wrong, it's not everybody's agreeing. I'm not saying it's a come by our moment by any means, but there are people out there that get it. There are people out there that have got the authority and the power to change it. And to be fair, many of them are listening because they have to, because they can see what me and you can see, and they know sooner or later they're going to be held responsible for it. So unless they shift, and it's not easy, they have to shift the way they feel and the way they think in order to get different results. And they have to start asking different questions. Now, some will do it and they'll succeed, some won't do it, and I hope they get removed, frankly, and they fail, because we're paying for them anyway. So that's what's got to shift.
Now, Victor, you say you're an optimist. I'm going to test the levels of your optimism.
Oh my God, that could be a challenge.
If we're working towards a world of equality and equity where there is no inverse care law, that's what we're working towards.
That's what we've got to get to.
Is it achievable? Can we ever truly have an NHS which serves all of us in a way that is equitable?
Yeah, I mean, we did. So we know how to do it. As I say, for decades, the life expectancy, active and actual, of poor people went up and up and up, right? It's only recently where there's evidence, if you look at Michael Marmot's work, that started levelling off and in some cases falling. So we know how to do it. This is not impossible, right? But it has to be acknowledged how big the problem is, right? Before we can solve it.
And beyond the NHS as
well,
well,
it is beyond the NHS.
It's way beyond the NHS.
So we need health in all policies. Transport policy should be clear, and I've talked to leaders of local authorities who do this. For instance, don't bring me a policy on how we're going to manage the roads that's not going to contribute to the health of the population, right? Don't bring me a policy on any aspect of public health that isn't going to benefit the population's overall health. Education. How do you have an education policy which doesn't contribute to the well-being of children such that they're not, in and out of mental health institutions?
And all of those spheres come back to those three things that you identified in equity, access and digital.
Exactly. So so people tend to overcomplicate it. It's very simple. But actually, you need health in all policies to contribute to population health. And everybody needs to see it as their challenge. So it's not a you challenge, chief exec of the NHS. It's a we challenge. You have a major contribution to make, partly in reminding us it is a we challenge. The NHS can only do so much, but it's also a policy challenge and a political challenge. And frankly, we get the leaders we deserve. So if you're watching this podcast, it's you too.
Everybody's got a role to play.
Everybody's got a role to play.
I could talk to you about this all day, Victor, but thank you so much for sharing your wise words, your optimism, and hopefully inspiring everybody watching this podcast to just have a little think about what we've discussed, and is there anything, there's probably a little bit of something we can all do.
Absolutely.
Thank you. And thank you to Visionable for facilitating this conversation. I've loved this discussion. It's been really encouraging to hear that despite the inequalities and inequities that still exist today, there are promising innovations that are offering new solutions to tackle this societal challenge. If you're interested in finding out more about Visionable's mission to make healthcare more equitable and accessible for all, visit visionable.com.